Assalamu alaikum and good afternoon, dear participants. Rather, it's a bit late today. So today is our 67th lecture session, and today's our topic is ECG in Ischemia Infarction. Uh, our speaker is Professor Chaudhry Hafiz Ahsan sir. And before the start of the lecture, I'd like to request M. Athar Ali sir to introduce Chaudhry Hafiz Ahsan sir among our participants, and then we proceed. Athar Ali sir.
Thank you, Dr. Tushar, and good evening to all of our faculties and participants. Dear participants, today's presenter is Professor Chaudhry Hafizul Ahsan. Professor Chaudhry is a clinical professor of medicine, University of Nevada. He is already well known in this forum. He does not need any introduction. Professor Chaudhry is already known to our participants as an exceptional presenter. We always enjoy his presentation. He is outstanding in knowledge and skill. He is a very brilliant academic career, outstanding in knowledge and skill. He loves this country and we love him. Today's presenter is Professor Chaudhry Hafizul Ahsan. Everybody is waiting for his presentation. Dear participants, this is Professor Chaudhry Hafizul Ahsan.
Wow, that was a huge introduction. So let me see. Once I disconnect, I get scared about this uploading. I'm trying to find my EKG slide set.
হাফিজ ভাই
Oh, Adut bhai, welcome.
চলে আসছি একেবারে কোনো মতে দৌড়াইতে
আচ্ছা, আমার স্লাইড দেখা যাচ্ছে?
Nice.
Good. Okay, so I'm actually complimenting my I'm complimenting my fellows and also our two EP attending, Dr. Gururaj and Dr. Namazi. So my role is very minimal when I attend the EP class. Every week we have an EP class on Tuesday. So I just, in other days, I have to be active, like cath conference or in general cardiology journal club. But EP conference, I take a cup of coffee and then relax and I just enjoy the fight. So today I'm just presenting that EKG sets. So I really acknowledge the fellows and the attendings from that conference. 46-year-old motor vehicle accident. We are level 1 trauma center. So we get a lot of consults from them. So this was the EKG of that patient. So diagnosis, anyone.
Is there a Nepali friends from Nepal?
So this looks like sinus tachycardia. And then question is there something else possible? Is it possible to be atrial tach? The heart rate is 150, the ventricular rate. And some people say, okay, if it is 150, maybe it's atrial flutter 2 to 1. But the question is how you differentiate this.
Hafiz, why didn't you call somebody from here?
Okay, so yeah, I was waiting.
Dr. Abida, can you participate, Dr. Abida? Unmute, please.
It's a very simple EKG.
Or anyone from Nepal? Or anyone?
By the way, Rafiq bhai, pressure is on you now. I'm very encouraged. 79 participants.
Right.
Sir, Vishal Sriff has raised his hand.
Yeah,
He might speak.
Can I try, sir?
Yeah, sure, Vishal. Yes, welcome.
Yes, thank you, sir. So here is, sir, am I audible, sir?
Yes.
Yeah, yeah.
So, hello.
Yeah.
Yes, Vishal, we can hear you.
Yes,
Vishal,
sir.
please.
So here is a patient with the QRS. Sorry, this is a two-way lead ECG with rhythm lead strip showing probably taken in standard speed and voltage, showing narrow QRS complex regular tachycardia at the rate of around 150 beats per minute. And we can see the P wave is inverted in 3, and the P wave is upright in 2, and biphasic in V1, and upright in AVR. So it might be either coming from either coming from ESA node or near the ESA node. And as the rate is 150, so I would like to consider other tachycardia also beside just sinus tachycardia. Like
So-
I can consider, yes, sir.
Okay. So your
Go ahead.
primary diagnosis is sinus tachycardia, right?
Yes, sir. My primary diagnosis
Okay.
is sinus.
Anybody else wants to talk about it?
Small point. Look at the very far end. There is a calibration. So I tell my fellows that and tell them about this conference in the morning that the participants from Nepal, they are very particular about the speed check and also the calibration. And you can look at the
Oh,
very
yes,
far
yes, sir.
end of the EKG. There is a calibration. When you are looking at all the leads, at the very far end, look at the calibration. Sometimes the EKG take can speed up to 50 millimeter per second, and then it will look like wide QRS. So calibration is important. Thank you so much.
Sir, P wave seems to be negative in lead 2, sir. This is unlikely in sinus tachy, sir.
Yeah, well, this is the problem. The problem is 2 looks upright, but 3 and AVF
Yes,
doesn't
sir.
look upright. And if you look at V1 to V3, it's inverted, which kind of goes against sinus tachycardia. So it's a long RP tachycardia. And so long RP tachycardia differential diagnosis, of course, is sinus tachycardia, atrial tachycardia, and atypical AVNRT. If it were atypical AVNRT, 2-3 AVF should have been negative, and V1 should have been positive with a sharp, narrow P wave, which it is not. So I think it's most likely, Hafiz, you go ahead then.
No, to support what you just said, I show you the EKG now when he is in sinus rhythm. So remember Rafiq Bhai said about the P wave in 2 and 3, and then V1, V2. Now look, in sinus is distinctly positive. So,
Hafiz
so
bhai, can you go back to the previous ECG? It's very important. In V1, there's negative P wave, but that's not biphasic, not typical biphasic. If it were typical biphasic, then it would have been surely sinus tachycardia.
So, you know, I was thinking, why these, does it matter? But it can matter, because if it is remains same, then the therapy is also very important. So this is the rhythm strip, and they get frequent calls from the tele. So that's why I thought that this is important to show. And if you want to follow the P-wave algorithm, this is actually revised, you believe it or not, that how, what just Rafiq Bhai said about the V1, lead V1, and then lead 2-3 AVF. Look at this, how it can help you to identify whether this is coming from the tricuspid annulus or right atrium, or for that matter in the left side. If you're interested, you can look at this from the circulation 2021. Kistler said this. But let me go to the next patient. But before that, one thing I thought is important, that how you face this practically, that if it is atrial tach, and then not sinus, or ectopic atrial tach, or is it atypical AV nodal re-entry tach? If the patient is, usually they tolerate, the blood pressure was good. But if you want to control the rate, if you know, because sinus tachycardia, we normally don't want to treat. We don't want to treat we want to treat the underlying cause. So if you know that there is differential and you can control, then you can try medications to control it. So important thing is this one. This is a 57-year-old coming with lightheadedness, previous history of cabbage, hyperlipidemia and diabetic. And then when he came to the hospital, he has COVID positive, but no typical symptoms. So COVID is not a big issue. And this is the EKG. And I give you, this later part, I challenge you, because Friday evening is our weekend starts. So this, I make fun about this. This is a 4:30 in the afternoon, and you are on call, and you got this EKG. What do you want to do now?
Any volunteers, please?
May I try, sir?
Again, Vishal, right?
Yes, sir. This is a 2 LED ECG with strip, rhythm strips taken in 10 mm per millivolt and standard showing P wave at the different rate than QRS wave with complete desynchrony, and QRS wave showing alternating RVV and LVV pattern. Especially we can see in V1. So I think it is a advanced conduction disease with complete heart block. And I'll do temporal pacing in this kind of patient.
What do you mean by advanced
I
heart
mean,
block?
there is both alternating RVV, LVV, as well as complete heart block.
Do you think there is? Do you think there is conduction?
No, sir. This what I mean to say is this escape rhythm is coming either once from left ventricle and once from right ventricle. I think so. So this signifies very unstable patient. It might be very unstable patient. He or she might develop complete arrest or Brady-induced VTBF soon. So I'll consider this and do early TPI or pacemakers. And obviously the beta blockers will be stopped, and if there is any, yes.
The beta blocker, do you think the beta blocker is causing it?
No, sir, I don't think this is the cause, but still at present I'll hold it, and again after insertion of pacemaker, I'll build up it as a other case, as in other case.
So there's a problem with beta blocker, because beta blocker, every time somebody comes with heart block, people worry about the beta blocker. Please, you have to remember something, that beta blocker works more on adrenergic receptors. AV node influence on the beta blocker influence on the AV node is not great. So it is very, very unlikely for a beta blocker to cause complete. I'm not talking about this case. This case, it's a very, very low dose. But even if somebody has 100 milligram BID of metoprolol and comes with complete heart block, and the heart sinus rate is what it is here, it is unlikely to be beta blocker, because if the beta blocker is causing it, it will first cause extreme sinus bradycardia. And it may cause, very unlikely, but still can cause, but you will have underlying marked sinus bradycardia if that's due to beta blocker. Thank you.
So this is the analogy I give. patient took aspirin, had a GI and upper GI bleed. You stop the aspirin, but still do endoscopy. Aspirin may be precipitating, but aspirin is not the underlying issue is there. The analogy may not be great, but that's the way I take it. And this is the reason I showed that this is at 4:30 in the afternoon on a Friday. Question is, will you stop the beta blocker and watch, or you will put the temporary wire? You have to push temporary wire. This is a very unreliable rhythm. So just stopping the beta blocker will not cut it. Rafiq bhai, you agree?
There's no question. I mean, 4 o'clock, that's the time to put a temporary pacemaker in. If patient was, even if the beta blocker dose was high, I would only wait for temporary if the QRS was narrow, escape rhythm was narrow. But with the wide QRS, especially alternating right and left, definitely temporary pacemaker.
So I tell you, some of our cardiologists and senior fellows will do the following: stop the beta blocker, put a pacer pad, and then start dopamine or isoprenaline, which is absolutely not acceptable. Okay, because it may go into a big trouble in the night, because these are not going to help, and you may be in trouble. Let me tell you a few other things. So the way I look at this EKG, is it tachycardia or bradycardia? This is significant bradycardia, and the bradycardia denoted by the RR interval, and the RR interval is regular. But if you map the PP interval, also regular. So PP interval gives you atrial rhythm, atrial rate, and then RR interval gives you the ventricular rate. And now you look at the association. The P and QRS, there is no association. It is totally dissociation. So atrial rate higher, ventricular rate lower, and there is AV dissociation. So this is complete heart block. Question now, where is the escape rhythm coming? Because there is no control of the atria over the ventricle now, and the ventricular escape rhythm is not coming from the junction. It is coming further down the junction. So if it is not coming from the junction and narrow, then the Purkinje system is very infranodal, and infranodal block is very unreliable. So therefore, it is important to pace this patient. If you are the EP guy in the night and you want to do a permanent, please do permanent. But I tell the fellows, at least listen to the heart. There is no aortic stenosis, there is no murmur, and do an echo before putting a permanent device. The people sometimes go enthusiastically put a permanent, and then the EF is like 20%. That's not acceptable either. So Rafiq, any other comment?
No, definitely. I mean, you're good. I mean, we always get echo before we put a permanent pacemaker in, because it really saves a lot of hassle later on.
Sir, can I ask you one thing, sir? Yes, patients like EF is low, but it's not like below 35 degree, 35%. So do we take any consideration for like CRT or something like that, sir? CRTD or something, ICD, something like that? If it had been less than 35, yes, definitely we would have thought. But if it is like this, and EF is around 45.
So before Rafiq Bhai answers, let me answer in a general cardiology way before you deep dive to EP. So if the EF is normal, good. If the EF is above 35, then you ask yourself, should I open up the Pandora's box now, or I can open up the Pandora's box later? Because you can still put a permanent pacemaker because EF is good, there is no significant valve disease, and look up the ischemia workup later. Hopefully you excluded the valve disease. If the EF is bad, then before we put any device, you really need to look at why the EF is bad. Is it ischemic etiology or non-ischemic etiology, any valve disease? Of course, echo will tell you about the valve. But if the valve excluded, then you really need to, if the patient is 30-year-old drug abuse or viral myocarditis, you don't need to do a cath probably. But if it is a 70-year-old with bad EF and never been worked up before, I think we are obligated before we put a $70,000 ICD device to look at the ischemic etiology. Who knows? It could be significant left main multivessel, and by revascularization, patient EF may get better, so you don't need an ICD device. But you just keep the temporary wire, get the ischemia workup, and then get the EF better before you put the more expensive ICD.
Yes, sir. Yes, this patient already had gone CAVG and she is like high risk, high ischemic risk.
Yeah.
And EF is 45%, sorry. So
Yeah.
if
We
it
just
had
give
been
a
like less than 35%, there was no question like we will go for CRT. But when like 40, 45 EF and if the NOS is 2, 3, then is it like off-label use or we do not use it at all, sir?
So excellent point. The next level of question. That patient's heart rate actually with the temporary wire and then off beta blocker following morning was this sinus rhythm left bundle. And I'll tell you what we did.
The escape rhythm was right bundle.
Right. Good observation. So there is a chance that he would be paced. So, and then alternative bundle. So we actually went for BIV paced, but not ICD. Atharva, do you have any comment?
So,
Yeah.
so you have gone for CRT.
Yeah.
Yeah.
So just to let you know, to avoid confusion, is the how you communicate. We usually call BIV paced, and CRT. We reserve that term that when we are giving ICD. But you and I, we are meaning the same thing. For the audience, what we are talking about, that we pace like a BIV pace, but there is no ICD. So the cost may be a little cheaper.
So CRTP, sir. CRT pacemaker.
Correct.
So, one of the things that we do here, what is the difference between medical care in United States and say Bangladesh, India, Nepal? We pay meticulous attention to patients. Patient comes to me in Baltimore or Pennsylvania. We try to get record from wherever it is available so that we can come up with a definitive plan for this patient long term. And then, of course, the question would be this one, of course, BIV pacing. The other option that we do nowadays, we do his bundle pacing. Okay, but that's the advantage is that if you have that skill, then you can get narrow QRS without having 3 wires in the but the most important thing that these treatments are individualized based on the disease pattern of the patient. In addition, also who the patient is. So that's so important to do. Thank you.
So this is a 77-year-old presenting with exertional dyspnea and told to report to ED because the outside EKG was like 40 heart rate and first degree AV block. This was the EKG.
Is there something on the downslope of the T wave as seen in V5?
Okay, anything else? So this patient, sinus rhythm, prolonged PR, and then electrolytes relatively normal. And then this happened overnight.
Yep.
Yes.
So now going into 2 to 1. And this is the same theme, that what you want to do, what kind of pacemaker you will give. So the concept is, if the patient is requiring too much pacing, then it is better to do the BiV pace. Any comment on Rafiq Bhai on his bundle pacing? Because not all EP physicians are fan of his bundle pacing, but some are.
Yeah, I mean, it depends on your level of experience. The other problem is that how much dependent the patient is on the. So this patient had 2 to 1 conduction. So probably doing his bundle. The other question is that if the EF is normal, majority of the patient do very well with apical pacing or septal pacing. And so across the board, if you find out the statistics that most people with EF over 50% will get a dual chamber pacemaker. Yeah, people, of course, are more and more getting into BiV or his bundle pacing if the EF is lower.
So another patient, a 76-year-old, and then an incidental COVID, but coming with COPD exacerbation. And then cardiology called in for tele changes overnight. This is the EKG in the beginning, and then this problem.
Mhm.
Any comment?
Did the patient pass out?
So I was looking for the timing, Rafiq Bhai. If you look at carefully, this is 13th of February at 12:32 a.m.
At midnight. So he was sleeping. Yeah. What is the body weight?
Body weight, I don't know, but
Sleep
I did see the patient. Be, you know, a little bit on the obese side, but not grossly obese.
Sure.
And we
Anybody has any
suspected
comment on the telestrip?
telestrip.
Anybody, any comment? Yeah, Junior. Nobody?
May I try, sir?
No, somebody else. We need to get others engaged into this thing. What's going on? Nobody is coming up. Listen, this is not an exam. This is a discussion and you should participate. Passive listening is okay, but the purpose of this session is not passive listening. You will participate, you will make mistake, I will make mistake, and we will fix it later on. And that's how we are going to learn. If we go for this traditional lecture that we used to listen to, sit there in the back of the class and keep listening, I attended all the lectures, basically learn nothing. That's not good. That is not the purpose of this session. So please do come forward and talk about these kind of things. Okay, Hafiz, go ahead.
So this was clearly long pauses. And the question is, with somebody suspecting this obstructive sleep apnea and during sleep, how long pause you tolerate? The patient doesn't have any syncope, as Rafiq Bhai was asking. And then of note, initial RR interval is not multiple of the original RR interval. So this, how you differentiate sinoatrial exit block versus just sinus arrest. But your observation is clear, right? That you don't see any activities. So how long you wait before you say this is significant and you need to have a pacemaker backup? This was almost like 10 seconds.
Well, I've seen pause up to 30 seconds.
Right.
And did nothing. This patient actually was seizing. If the reason I wanted somebody to comment on the strip, if you look at the strip, when the pause, after the pause towards the end, you can see the baseline artifacts. So I wonder if in sleep he was seizing or not. Without symptom, I mean, it's difficult, and especially this patient is very sick at that time. Temporary is different, but of course, one will have to really clearly debate about the role of permanent pacemaker in this patient. So,
And no other pauses noted in the next 30 hours in the hospital. So in the guidelines, it doesn't say how long, but some EP guys, particularly I called around the west side, more than 10 seconds, they get worried. Is that something arbitrary, Rafiq Bhai?
Nobody knows. I mean, listen, what somebody during sleep apnea patients, we see young people with obese people, 10, 15-second pause, and we don't put pacemaker in.
Right.
On the other hand, this guy who never has syncope just because he's elderly. The other issue would be that sometimes you have to assess the patient. Elderly patients, a lot of times they don't report symptoms. If there is a concern about that, that is have to be taken into consideration, because there are a lot of elderly people with mild dementia. They will not remember dizzy spells or minor blackout spells.
So, we have like 76 participants now. The reason I'm showing this, because many of us in this group are general cardiologists, not the EP docs.
Yeah.
For us, sometimes it is easy to make the decision for pacemaker. And some of us do the pacemaker and will be very easily vulnerable to make the decision that, oh, pause, put a pacemaker. But if it is this, I think the harder part is that to make a wise decision, I would say wise, because that is more appropriate, then don't jump on putting a pacemaker. And the more importantly, if you are not sure, then ask someone who is the authority in that line and then put a pacemaker. The easy path is to put a pacemaker, but that may be inappropriate. I think that is fair to say. Rafiq Bhai, you agree with that?
Yeah,
Athar Bhai?
For the audience, I don't know if you paid attention to this thing. Hafiz said, I called people along the West Coast. And this is something that we always do. I mean, we always talk to each other. I mean, I have been in practice for 30 plus years. Even then, I talk to somebody else who has been in practice for 10 years. And we call around people and find out, not to, just to confirm that what I'm doing is the right thing. Because these are the gray zones that you have to make a decision. And this is something that I think I see a little lacking in Southeast Asia, because I don't know why, but there is this thing. But we always talk to each other. I mean, we call each other. Hafiz calls me, I call my partners. I have called partners who just joined 2 years ago because they come with new ideas, new brain, and they may have something new that I just didn't pay attention to. Thank you.
So when you become
can
a doctor, when you become a doctor, yes, sorry, go ahead.
Can I ask a question? Let's say
Yeah.
the previous patient.
Yeah.
Apparently, he is asymptomatic. But
Yeah.
if they find out his anti-proBNP is quite high, what will be your decision?
BNP is high.
Yeah.
So that's probably preserved EF, BNP high, probably is a component of diastolic dysfunction. Whether that will change the management in terms of pacemaker?
Yeah, that's the question I'm asking.
Only thing is the syncope is the solid thing that
Yeah,
will go
yeah.
for pacemaker.
Yeah.
Yeah. Even dizziness, you scratch your head.
So Hafiz, I mean,
Yeah.
this patient was on metoprolol 12.5 BID. So just recently, I saw another gentleman who was 70 plus and was in neurologist office for stroke evaluation, and he dozed off or passed out momentarily. When he came, he was having these pauses, but he was on metoprolol 100 BID, and we stopped it. It all disappeared. So that was one case that, and this is also very low dose metoprolol 30 BID, but in elderly, sometimes they actually react more than younger people.
Yeah, agree. And we did take care of this metoprolol off and then control with other medications for the hypertension. So what I was going to say that I usually tell my fellows, when you become a physician, you accept everything, you take everything, but you give up one thing for sure, that you give up your ego. Take the ego off when you become a bedside physician, because
Excellent.
you never know what will come up on your way. 76-year-old, COPD, and then, sorry, let me, I showed that one. This is the one that probably will be the case of the day. A 78-year-old had cardioversion, pancreatic cancer, Whipple's 2013, hypothyroidism, diabetes, and then came in with some mechanical fall, denies that he has any loss of consciousness. And initial evaluation, the troponin, high sensitivity troponin, 5th generation, some minor temporal change, and then thyroid TSH is high, magnesium little low, and this is the EKG. So any comment on this EKG? Because there will be more to come.
Well, the heart has not decided which way it will go. All sorts of arrhythmia.
So we read it as AFib and then PVC.
Yeah.
And then this happened overnight.
Uh-huh. What was the potassium at that time?
Potassium was okay, I think.
3. Potassium was hypokalemic, sir. 3.
No, wait. So 3 and 1.28 on the day of admission, but it was corrected. So we do not know what was at that time, but the following morning, after this happened, checked a couple of hours later, the report came and the potassium was okay at that time. Magnesium was 1.8. But very good point. There are more to come. That's why I'm telling you this. So it was read as, so this is the thing, this, and this is the reason I was very involved. So the fellow read that this is the VTAC, ventricular tachycardia, and polymorphic ventricular tachycardia. The attending said, no, this is AFib with fast ventricular rate and aberrancy.
True, I am in this favor.
And the attending was EP attending. So
all EP things alike.
okay, now this happened after that, and now the fellow went back to the EP attending and then came to me, but we both were blinded and saying that, what do you think?
So this is again in favor of the AFib, Chaudhuri.
Okay. Any other comment? So fellow was very naughty. He showed me this one and told the EP attending that Asan said this is polymorphic VT, and then then meaning that I supported him on this one also, which I did not even see. So my question to you, Athar, is it two different arrhythmias or same AFib happening here also? Because
Sorry?
when I looked at this, I thought that there is irregularity in this one, the green one. There is irregularity of the RR interval, although there is some amplitude variation, but here it looks like wider and different and pretty regular.
So this is in favor of the AFib because the initial part clearly shows the irregularity of the RR interval and there is no POF. So the initial part of the strip is in favor of the atrial fibrillation. Just before the wide QRS complex, there is long short interval. There is the just before the wide complex, there is a short pause, long pause, short pause. So these pauses can causes variation of the refractory period and causes of the widening of the QRS complexes. And this widening in not against the VTS because the widening in the same direction of the sign, that is the previous conducted bit. If it are the VT, it should be go usually opposite direction. That is, you see, the direction is the same. That is the conducted QRS and the wide QRS in the same direction. Usually in case of the VT, it should happen downwards. So irregularity and the same direction in favor of the VT. That is the AFib with aberrancy.
Okay.
So
Hafiz,
if
can
I
you
show
go back?
you this,
Hafiz, go back,
Yeah.
please. Go back,
Yeah.
please. More. One more back, please. Okay. So no, that's ECG. Next one.
yeah, next one.
No, the next ECG. Yeah. So, I mean, look at the top strip. If you look at the top strip, the one that is marked N, and then the first one says S, and then says V. Look at the change in morphology. It is changing gradually. So the first one that is marked S is probably a fusion beat. I'll tell you why I think it's fusion. If you look at the second rhythm strips, look at, even though the rate is fast, it's not aberrantly conducted. So those first 5 or 6 beats, I think those are ventricular. And then it becomes normal. And look at the first 2 beats of the wide complex. There is a fusion and then changes. So I think, and then it goes into AFib. And then in the bottom, you can see regular wide QRS. So I think that's the initially non-sustained first couple of fusion beats. And then and the next one, it will be hard pressed not to call it VT, unless somebody can show me a 12 lead that shows that it's just the lead position. Sometimes you get funny looking QRS complexes.
And then this long short concept, Rafiq Bhai, but if there is any aberrancy in the AFib with aberrancy, do you see change in axis, or it is just aberrancy taking a change in morphology, like becomes an aberrant bundle branch, but you
Okay.
don't see any axis change.
All right. So let me explain this to you. Let's look at the top strip. I'm looking at the 3 marked N and N. If I assume that is V6, looks like V6, right? Or lead 1. In that case, you would have seen a tall R wave with a terminal S wave, not so deep. That will be right bundle aberration. If you're left bundle aberration, you will see a wide left bundle type. So that QRS complex does not fit into our classic aberrant QRS complex pattern.
Mhm.
That makes me think that this is not aberration.
Correct. And then in the lower panel, that in the very lower panel, that clearly there is a change in axis from NNN to VVV, and then very wide. So this is probably double tachycardia, AFib going into polymorphic VT.
Yeah. So can I ask you, all the young doctors that why are you just talking about this stupid ECG? You know, there is a reason for it. We can just pass by and call it AFib with RVR or make our brain think. And that is the whole point that we are trying to do here, that you don't ignore anything. You don't just pass by, hey, this is AFib with RVR and then go away. And if we do that, the day we start doing it, that's the day we are going to miss VT, which will become disastrous for the patient.
Yep.
Rafi
And
sir,
then, and there,
Yeah.
yeah, go ahead, Tushar.
Sir, I have a question to both of you. Sir, is that the initial irregularity supports VT more than the AFib? Because we know in VT, that can be variable heart rate initially. And the lower panel, the wideness of the QRS and the regularity that later comes on, clearly suggesting VT. And it's the VT that can have some irregularity in the initial part. Is it possible, sir?
You see, irregular, I'll put it the other way. Just because something is irregular doesn't mean that it cannot be VT.
Yeah. And we actually encourage our fellows to look at the cycle length tediously and see whether there is any pattern in the cycle length. Because unless you are very meticulous in measuring cycle length, the eyeball cannot be very reliable when the ventricular rate is too fast.
Okay, so what happened next?
Yeah.
Go ahead, Hafiz.
So now I just wanted to show you
Hafiz, can you go back? There is some clue here. Go back.
I was going to come back to that. Okay, yeah, go.
So
Vivek.
Don't pay attention to the top. Look at the end where it stops. You see, aberration will not stop like that. If you with RVR, with aberrant conduction, it will gradually slow down. Will not suddenly switch morphology.
Yeah, and it stops.
Thanks.
So this was the echo. And I told you that this patient had a Whipple surgery and this LV is bad. So any suggestion what to do next? Jamil bhai, Wadud, any suggestion?
Well, I mean, you need to do the full work. I mean, the first thing is that if you see white QRS, you rule out ischemia. And when I prefer cath to be done. Oh, you did the cath. Okay. What did you find?
So this was the left dominant system. We did the cath. And this is like a dual ostia LAD and SARC coming separately. Nothing striking in the cath to explain for the cardiomyopathy. There is plaque, there is calcification, and then we did the osteal LAD, IFR, FFR also, and a negative. Right is non-dominant. Now what?
Sir, the
And by the
septal,
way, to answer Wadud's question, this second episode happened when the magnesium and the potassium were normal, but magnesium was given more. And also, like anywhere else, they gave amiodarone IV also. And then amiodarone infusion that later on was stopped when the patient came to sinus, rate control, AFib.
So what is the calculated EF, Hafiz?
EF, well, the calculation is eyeball calculation, but
Yeah.
the EF is like semi-quantitative 20% EF.
Yeah. Okay.
And then there was a pleural effusion.
sir, he's looking at his echo. Septal wall was a bit hypokinetic, and there are some increased sort of thickening. So I want to rule out the amyloidosis, sir. Just came in mind. I may be wrong, but it first strikes me. The septal wall, looking at the septal wall.
Okay, so since you mentioned this, it is important to mention that cardiac amyloid in an infiltrative cardiomyopathy can give rise to LV dysfunction later, and then wall thickness. And then for the ATR amyloid, we are now doing the pyrophosphate scan. This is not the AL amyloid that we know from multiple myeloma and amyloid. So it is a completely different. And the reason we are meticulous now about it, because there is a treatment available, although this is very expensive. But think about this patient, that this is a patient with Whipple's, multiple chemotherapy, and then has cardiomyopathy and non-ischemic. So we thought that this is most likely chemo related and not any infiltrative cardiomyopathy, right? And God will be really unkind. I don't know why I'm bringing God here, but to have two bad diseases at the same time. He has enough already with the Whipple's and then pancreatic C and all that. And now has bad EF. And in addition, we are suspecting amyloid. So we did not go that route, although this was actually discussed in the conference. And are you an EP doc also?
Sir, I work in the EP department.
Perfect, because I see that all the EP docs think about the same line, but I did not pursue further for the pyrophosphate scan, and I'll tell you why. And that is one of the reasons I'm showing this case, that why I'm not pursuing that any further.
I have a question.
Yeah.
What is the status of pancreatic cancer?
Oh, Rafiq, I love you. So
yeah.
So that is the key. That is the key. That whatever we do, we need to understand this. But let me tell you this a little bit further about the polymorphic VT. That, this is sometimes a problem, and you can see that the atrial arrhythmias with ventricular pre-excitation, even artifact, can be sometimes a mimicry. And then if you go to the left side, then they talk about long QT and not long QT, and then whether this is polymorphic or this is torsade. I think that is important to consider, but even more important is to see whether there is any organic heart disease, ischemia, valve disease. And then in the young population, think about the channelopathies and then catecholaminergic induced VT. Pause dependent can be an issue. So drug induced bradycardia in the long QT, and then post tachycardia, sometimes long pause. In our patients, that actually happened probably. And then you can see this even in Takasubu. We have seen that in the COVID time also. So short coupling interval and then induce the polymorphic VT, you cannot differentiate. The left one, I took it from the book, that it is on the young patients with catecholamine dependent polymorphic VT, and in the right side, this is actually STEMI patient, where the short coupling interval and then induction of the polymorphic VT. So it is important to rule out structural heart disease, coronary ischemia, and then decide about what to do. So back to our patient. ICD, if we summarize this, that what is the purpose of giving the ICD? To prevent sudden cardiac death. Is it a primary prevention or secondary prevention? In our patient, this is secondary prevention because it sustained the polymorphic VT. But more importantly, it is also important to look at the presence of comorbidities. So, and this is a risk and benefit, that we are preventing sudden cardiac death and nasty ventricular arrhythmia and abort, and by time. On the other hand, what is the comorbidities? What is the procedural risk? And I'm sure cost is an important issue. So in our patient, we asked the oncologist, what is the likelihood of this patient's survival? I don't know what you follow, but generally, even for secondary prevention, 1 year survival is the key to follow. If the survival is poor, then we don't want to put an ICD, even for secondary prevention. And that's why we are asking the prognosis, as Rafiq Bhai pointed out. And then we talked to the oncologist, they're waiting for some scans. So not ideal, but we just gave the guidelines directed medical therapy for LV dysfunction because of the cardiomyopathy. And then we actually wanted to know the prognosis. Initially, we planned for live vest to buy time, but the scan came in as the recurrence of the malignancy. And therefore, I did not go for any infiltrative cardiomyopathy to look for. And the prognosis was not more than 6 months. So he did not get the ICD.
You know, it's so important. So I'll give an example of a patient that I saw recently. He was, I think, 87, very fit 87-year-old, came with sustained monomorphic VT, a cardiomyopathy. But he said, Dr. Ahmed, I just want to attend my granddaughter's wedding in July and my great-grandchild's first birthday in September. So we made a decision in consultation with the patient that we're going to give him a live vest until that first birthday. And then after that, he will decide what to do. And of course, this is another situation where this is where we really need to get involved and talk to patients in a very, very, as a patient advocate, and make a decision what to do. Thank you.
Yeah. So we did not
medical
go any
therapy,
further.
what do we have used, sir,
Yeah.
for rate control and this?
Was that?
Sir, for medical therapy, what drug did we choose, sir?
So we actually used amiodarone, PO, and also carvedilol.
Thank you, sir. And if it the prognosis was good, then would you consider ICD or CRT, sir?
So this patient less,
No,
we
if the
were
prognosis
considering,
was good, like
we
if
were
the prognosis
considering,
was good, like
I would say, I'm not the expert on the ICD, but I would just give a single chamber ICD. I would not put by V ICD because the patient is not really, or probably would not be dependent on pacer.
So in a cancer patient, I put it very bluntly. If the cancer is cured, I say, look, I am going to treat you like a normal person. If the cancer is not cured, then I ask him, do you want to die in agony or die suddenly of VF? And I don't put it so bluntly to the patient, but we actually put it the question that way. Look, which one would you prefer? And that's how you have to make a decision of ICD implant in cancer patients. And of course, the CRTD part depends on the patient's symptom and ECG presentation, all those things. And I remember that this is a very sick patient, so this patient symptom will be very, very difficult to assess.
I was
Yeah.
hoping that we find a ischemia substrate and we can take care of it. The most powerful antiarrhythmic is anti-ischemia therapy.
Yeah. Go ahead, Tushar.
Sir, regarding the ICD, sir, many times we see the patients we're treating with ICD needs antiarrhythmic drugs, which later on results in conduction abnormality, and they requires also pacing. So those patients who are gonna need antiarrhythmics, are they better suited for dual chamber and ICD?
So the question is, will you put a dual chamber defibrillator for patients because patient may need antiarrhythmic? We don't, because not all antiarrhythmic will cause conduction system disease. If they declare themselves, if we treat somebody with antiarrhythmic and we find that they have a problem that they will need dual chamber system, yes, we'll do it. Remember one thing that I used to do, a majority of my patients used to be dual chamber ICDs, but you were adding extra hardware, you were taking the risk of complication, lead disturbance, all those things. So now I really want them to prove themselves that they need a dual chamber system.
So Tushar, we are learning from the world history that preemptive strike doesn't work. We learned this in Iraq, that you have a 50% plaque, so you strike preemptively, it doesn't work. And
Yes,
then
exactly.
and then Ukraine may join NATO, so do preemptive strike, and then you make a mess. So preemptive strike, I think definitely there is no role for preemptive strike in interventional cardiology. Preemptive, there is no role. And now I'm hearing that there is no role for preemptive strike in EP either. So let's take care of things that is on hand.
So Tushar,
Sir, this is 10:45, so
Yeah.
we can conclude the session. Before conclusion, I'd like to request Professor Rahiduzzaman sir to say some words regarding the presentation and our program, and then we should conclude. Rahiduzzaman sir.
Sorry,
Well,
Tushar, I was a little late.
I was not planning to attend the session, but I'm glad that I did. It was an enjoyable session, a beautiful session, and of course, I hope that our audience took something from it, from this. And Hafiz, of course, I will always say good things about Hafiz, so I'm not going to say it because he deserves it. It's not that I say it because I like him, but he deserves it. The part that I like about Hafiz is he's a true Bangladeshi, and there are not many around. In Bangladesh, there are many, but outside, yes, not many like Hafiz. It's always a pleasure and my privilege to know him. Thanks, Hafiz.
One thing that I wanted to say, I really enjoy having the attendees, and please ask us questions. We are not your examiners. We are your senior colleagues, maybe because I'm old, but please feel free. And this is the time I tell my fellows, whatever you ask, whatever you do, whatever mistakes, this is your time to do that. Once you graduate, there'll be nobody around you. So you will be on your own. So it is better that you do all these things now, and don't be shy. And just ask, and you will find out that there are people who do not ask. They are not any better than you. So please participate. It will be more fun if you say your things. And Rafiq Bhai and we always say this, and you also know that your teachers, and when Wadud or Athar Bhai, they are your examiners, but I know that they will not penalize you for asking questions. I can guarantee that. Wadud, you will support that?
Definitely, definitely.
So it will not go against you. Thank you, thank you.
Tushar,
Sir,
it is special thanks to our Vishal Shrestha and Chitrora Sharma from Nepal and Arun Maski after a long time. Arun Maski.
Yeah, Orul, we
Yeah.
are seeing you after a long time.
sir was
yeah.
absent for some time.
Yeah, I was absent for some time. Nice
I
to
must
see
tell
you
you
all.
this, the people that our participants from Nepal, they talk because of Professor Arun Maski. I
Right,
think
right.
he's much more friendly than our Bangladeshi faculty to their students.
So, Arun Maski, we are waiting for your session in shortly.
Yeah, I'll see you in Dhaka.
Yes.
Okay.
Orul,
Welcome.
he will be coming in the IPDI conference.
Achha, we have
I-
got some.
I'll be also coming for Sky also,
Okay, na?
23rd to 27th.
Okay. Achha,
Oh, I'll meet you there.
Oh, yeah, sure. Yeah.
Okay, thank you.
You're coming to Sky.
Yeah, the Bangladesh guy. Yeah,
Yeah.
thank you.
And Hafiz Bhai, you can join in our program through Zoom. We will be arranging that. We are
Achha.
lucky that Rafiq sir is here.
Yeah.
So he'll be in person.
So,
Okay.
Abdullah
All right,
Chaudhary,
thank you.
please. Concluding remarks, Abdullah Chaudhary.
Well, any session from Chaudhary Hafizul Hasan and Professor Rafiq sir, they are very much enjoyable for two reasons. They bring beautiful challenging cases and then they explain it beautifully. So we can enjoy it. Most of us are not EP guys, as Hafiz Bhai used to say. So these challenging cases, when they are explained, that it makes sense to us. Today's cases are important in another context that they help us to gain some insight when to do, what to do, and when not to do. That's very important. Thank you, Hafiz Bhai. Thank you, Rafiq sir. Thank you, audience, for joining with us.
So, thanks everybody. Our next session is 27th of this month. Thank you everybody for the next session.
Sir.
Hafiz Bhai, খুব ভালো কি ইয়ে ছিল?
No, excellent. Mane, all the cases were, I don't know how he prepared these cases. Unbelievable.
ইন্টারেস্টিং হচ্ছে স্যার এইরকম কমপ্লিকেটেড জায়গায় আমাদের পেশেন্টটা খুব কমই পৌঁছাতে পারে। হুইপলস, তারপরে লাস্ট কেস যেটা ছিল স্যার, যেটা হাফিজ স্যার দেখালেন, মানে এতগুলো স্টেজ পার হয়ে পেশেন্ট আমাদের কাছে, মানে আমরা এরকম পেশেন্ট স্যার খুব কমই পাই।
তার আগে আজিমপুর চলে যায় নাকি?
জি এক্স্যাক্টলি স্যার, মানে এত কোমরবিডিটি নিয়ে আমাদের আমরা এগুলো চিন্তা করব বা অ্যাপ্রোচ করব, সেই পর্যায়ে আমরা যেতে পারি না আসলে মোস্ট অফ দ্য টাইম।
কোমরবিডিটি থাকলে আমাদের এখানে আসলে এই অ্যাগ্রেসিভ ট্রিটমেন্ট করতে আর রাজি হয় না কেউ। এত এক্সপেন্সিভ ট্রিটমেন্ট গুলো।
এবং আরেকটা জিনিস বলতে স্যার, আমাদের ইন্টিগ্রেটেড ম্যানেজমেন্ট যেটা প্রাইভেট সেক্টরে হলো, গভর্নমেন্ট সেক্টরে ইন্টিগ্রেটেড ম্যানেজমেন্টের ক্ষেত্রে আমরা কিন্তু স্যার বিপদে পড়ে যাই। মানে যেখানে কার্ডিওলজিস্ট, অনকোলজিস্ট বা কার্ডিওলজিস্ট, নেফ্রোলজিস্ট, রেসপিরেটরি মেডিসিন স্পেশালিস্ট, এন্ডোক্রাইনোলজিস্ট, চারটা গ্রুপ অফ পিপল একসাথে কাজ করতে হবে। এরকম কোনো কেস যদি আসে, এই পেশেন্ট গুলো কিন্তু স্যার আমরা লুজও করি এবং এদের ম্যানেজমেন্টটা হয়তো আমরা আপ টু দ্য মার্ক ম্যানেজমেন্ট আমরা হয়তো দিতে পারিনি, বিকজ অফ দ্য টাইম কনস্ট্রেইন অর কোঅর্ডিনেটেড অ্যাপ্রোচের কারণে খুব ডিফিকাল্ট হয়ে যায়।
আচ্ছা, আমার মনে হয় again thanks to Swadesh Chakraborty. Swadesh.
Sir, thank you, sir.
Thank you so much, Sadesh, for your being with us. Sadesh Chakraborty, Waliul Islam,
উনি ওয়ালিল ইসলাম স্যারও ছিলেন, কেবল লিফট
MG Azam. Actually, I got MG Azam, Jillur Rahman. Thanks everybody for staying with us.
থ্যাংক ইউ স্যার and good night.
Good night.
Thank you, sir. Assalamu alaikum.
Special thanks to Rivu. Thank you.